Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Pierre Laumonerie from Paris, France. After completing his medical school in Limoges, France, Dr. Laumonerie completed his orthopedic surgery residency at the Pierre Riquet University Hospital in Toulouse, France. He went on to complete an Universitat Diploma of Hand Surgery at the Institut Locomotor in Toulouse University Hospital, France. Subsequently, he completed a fellowship at the Mayo Clinic in Rochester, Minnesota, and also in Antwerp, Belgium. If you noticed, Dr. Laumonerie has delivered lecture on our channel and it's already reached a huge audience. And today it's my great honor to bring back Dr. Pierre Laumonerie for yet another wonderful live program. Over to Pierre.
Hello, everyone. First of all, I'd like to start by thanking you for inviting me to share my expertise on elbow surgery. So acute elbow dislocation associated with fractures of the radial head and the coronary process were coined terrible triad of the elbow by Hotchkiss in 1996 due to their historical poor outcome. And this injury have long challenged surgeons both in understanding their mechanism and in achieving optimal treatment. Many approaches to the treatment of terrible triad injuries have been proposed and followed with little scientific evidence to support them. And clinical studies have struggled to replicate in vitro findings in the injury mechanism. However, over the last 20 years, significant progress has been made breaking the myth of the terrible triad of the elbow. And sorry for the bug. The terrible triad is a complex dislocation with associated osseous injury. So it's a complex dislocation, but to understand this entity, it's essential to first recognize that it represents an acute PLRI, an acute posterolateral rotatory instability. And so this requires a thorough understanding of the ligamentous anatomy that contributes to elbow stability, as these structures are often damaged during such dislocation. And to keep it brief, I just will explain these ligaments. First of all, the LCL complex. So you have the lateral radial collateral ligaments and the lateral ulnar collateral ligaments that forms the lateral collateral ligament complex. And this complex plays a role in the PLRI instability, of course, but its contribution to the various stability of the elbow is limited. It's essentially a complex ligament for the PLRI. But more recently, Adam Watts and his team described the posterolateral ligaments, which completes the lateral collateral ligament complex. And it's important because we use this ligament to stabilize our elbow. On the other side, in the inner side, we typically find the medial collateral ligament with its anterior and posterior bundles. We did not represent the transverse bundle because he has a little non-clinical significance. The MCL is a major contributor to the elbow stability in valgus. Depending on the flexion extension arc, it will be either the anterior or posterior bundle that is engaged. So who first describes the PLRI? To whom do we owe the concept of PLRI? And the origin of this notion clearly lies with Cottrell and Osborne, who are credited as its authors. In 1966, they published a brief review of patients with elbow dislocation. They observed that their patient fell onto their hands with the elbow in semi-extended position. And actually, which caused axial compression with an hypersupination, and a valgus, ultimately leading to the disengagement of the coronoid and the radial head. This was an equivalent of dislocation, but a very special dislocation. They named this injury mechanism PLRI for posterolateral rotatory instability. We are in 1966, and this is where the story of the PLRI begins. But for the authors, it's not the end, because in the same paper, the authors identify the notches on the posterior surface of the capitulum as a cause of persistent instability, which would later be known as the Osborne and Cottrell lesion. It's a very famous lesion now. However, the authors did not stop there, because they proposed a treatment for the PLRI, and they recommended suturing the lateral collateral ligament complex in case of PLRI. But if the suturing was insufficient, the suturing of the medial collateral ligament complex was also proposed by the authors. So it was very modern, in fact. And what began as more a speculation became a reality in the following years, when Hartmann and his team published excellent results achieved through LCL suturing in a small series of patients with PLRI, and we were around the 70s. However, our modern understanding of elbow stability is largely owed to a great man of elbow surgery. It's Professor Murray. Professor Murray and his groundbreaking biomechanical work in the 80s. In a landmark paper, he notably demonstrated that the rupture of the MCL leads to a collapse of the elbow stability in valgus, while the LCL has a negligible impact. Murray, as well as Hotchkiss, would identify the main stabilizer of the elbow in valgus and assign the MCL a crucial pivotal role. It's a crucial role in valgus stability. And by the way, the LCL had a minor contribution to the varus stability. In 1992, O'Driscoll described the Horry circle illustrating the sequential soft tissue and bony injuries according to the spectrum of instability. The circle started from the lateral structure of the elbow and progressed according 3 stages to the medial structures, lateral from medial. And for the stage 3 concerns the dislocated elbow caused by the disruption of the LCL complex and the posterior and/or anterior band of the MCL. The anterior band was the most critical stage. The circle of Horry described by O'Driscoll and his team state that the terrible triad injury could occur regardless the status of the anterior MCL. The authors speculated that the radial head and coronoid fracture dissipated the energy of impact and stopped the progression of the circle before the elbow dislocation. And therefore, they supported that the stability of the elbow could be restored by the stabilization of the radiocapitular joint. According to O'Driscoll, the instability caused by a combination of axial load on the elbow at the time of the fall, coupled with valgus stress and a moment of hypersupination. For the Mayo team, it's the moment of hypersupination that may predominate, because it's the LCUL injury that is the main injury, and thus explaining the lateral to medial direction of the injury mechanism. You have to understand that a recent study, and notably that of the Korean team led by Ryu, have shown a strong predominance of valgus. And personally, I find this more recent theory to be more compelling. This shift in understanding has significant implication for the surgical management of patients. According to Ryu and colleagues, the injury begins on the medial side, similar to a reverse circle, in fact. They hypothesized that an axial and valgus load would likely rupture the MCL. This disruption combined with pathological hypersupination generates a lateral translation vector on the ulna. And this vector leads to elbow dislocation with simultaneous fracture of the radial head and the coronoid process. The stripping tip injury of the LUCL caused by the abruptment of the radial head against the posterior capitulum ultimately results in posterolateral dislocation, in fact. So he will present it as a new unifying theory through what I refer to as a reverse circle, because it's a reverse circle of the Aureus circle. And in 2018, Adam Watts and his team added a second circle to the reverse circle, resulting in the equivalent of a spiral around the elbow. The authors considered tendons to be less stiff than ligaments and speculated that the medial and then the lateral ligament complex will fail before the common flexor and extensor mass origins. And so dislocation is the driving force of the terrible Triad injury that makes it particularly challenging as the associated injury, and specifically the radial, it lags, and specifically the fracture of the radial head and the coronoid process. So as for the radial head fracture, there are injuries caused by the radial head passing beneath the capitulum, and there will inevitably be impaction of one or more fragments of the radial head, and even impaction will tilt of the radial head if the fracture occurs of the neck. Once you understand this, the logical reduction maneuver will involve disimpaction of the fragment with a spatula, initially worsening the displacement, and this will also provide the opportunity to remove the small central fragment, often encarcerated, and it may obstruct the reduction. Then the spatula rocking motion will be used to strengthen the disimpacted fragment. Once reduced, compression of the fracture seat is achieved with a pointed clamp between my hands, and the fracture is then temporarily fixed with two pins, followed by definitive fixation with two cannulated screws, either short or long thread. It doesn't matter, and I will not detail it here. If the neck is fractured, because sometimes you have a neck fracture of the radial head, screw can still be used with a tripod configuration, or alternatively a plate can be applied. Both setups offer equivalent resistance to the axial and rotational force involved. In the literature, the plate or the cross screw or tripod technique provide similar strength and stiffness for the fixation of transverse non-comminuted radial neck fracture. And my experience is that plate is more invasive with a risk of stiffness, even if the position of this later on the neck is good. So I assume that the plate is my last option when there is no other option, in fact. But the tripod technique is a biomechanical sound construct for the fixation of axially stable radial neck, and thus I don't use it in case of bone loss involving the neck, because there is a risk of malunion with an angulated radial neck. If you use a tripod technique for a radial neck fracture with a lack of bone on a partial neck, the cross screw or tripod technique can induce a malunion with an impaction of the radial head. Furthermore, if you push your screw, you can induce heterotopic ossification on the radial neck. So I think you have to avoid this technique for if there is a lack of bone, or if you have a risk to push your screw outside the bone. So the tripod fixation is very difficult to perform and should therefore be reserved for simple neck fracture and surgeon experienced in elbow surgery. However, it's my preferred method because it remains minimally invasive and causes no conflict with the proximal radio-ulnar nerve joint. In contrast, the plate requires significant soft tissue dissection and may cause conflict with the radial notch of the ulna if not positioned correctly in the safe zone. You can see it on the illustration with a conflict. For community fracture, you can use more screw, around 4, it's a maximum, after you have an increased risk of pseudoarthrosis, and you can combine a plate with screw. It's possible. But in fact, as you understand, what matters is the stability of your elbow. It's not really your radial head. It's really the stability of your elbow. And it's only elbow stability that we allow for early postoperative mobilization, a good function, and prevention of osteoarthritis. Therefore, one should not spend too much time on osteosynthesis with excessive screws, which expose to the risk of non-union. Instead, a quick decision for radial head arthroplasty should be performed. Radial head arthroplasty could give you excellent result and better result than an aggressive osteosynthesis. And so the third and final lesion of the cerebral triad is the coronoid. It's an injury that occurs during the humeral-ulnar dislocation. And in the cerebral triad, fracture of the tip represents the vast majority of coronoid fracture. But tip fractures are, as a rule, in the cerebral triad, and bone loss is minimal, but it's at the tip where the anterior capsule of the elbow inserts. So instability therefore arises from capsular insufficiency, and I often refer to this as a capsular fracture, in fact. Capsular fracture, I think, is a good name for this kind of fracture. The coronoid is a major contributor to stability in varus and a minor one in valgus. Several treatment options are possible. One option is to choose not to fix the capsule in elderly patient or those with restored elbow stability after fixation of the radial head and external ligament. But for in case of surgical treatment, we can fix it by an anchor. In fact, the focus should be on the capsular reattachment, as tip fracture are more equivalent to anterior capsule rupture than a coronoid fracture themselves. And you can see on the X-rays, it's very easy to do, but you have to be careful to avoid an effraction of the anchor in the joint, in the articular joint. It's not so easy to do, in fact. But you have more difficult fracture to fix. It's the rare case of mid-transverse. Mid-transverse involving approximately 50% of the coronoid height. This fracture significantly impairs the elbow's varus stability and increase the valgus stability too. The coronoid's bone buttress role and the stabilizing function of the anterior capsule in varus are then compromised. And so it's always a surgical treatment for these fractures. So you can use this plate and to fix the coronoid. And the other less invasive method to fix the fragment is retrograde screwing. By the plate, you can fix the fragment and you can do the ulnar nerve neurosis if there is a preoperative ulnar neuropathy, and you can fix the MCL by an anchor because you have done a medial approach. But if you want to avoid the medial approach, the retrograde screwing is a good option because it's less invasive and you can fix the coronoid by arthroscopy or by a small posterior approach. Finally, to summarize, the goal of the surgical management of the cerebral triad is to restore the maximal level of stability to enable the earliest possible start of the mobilization and to prevent persistent instability, which compromises functional prognosis and may lead to the development of long-term osteoarthritis. So I have supported sorry for the lag. I've supported a thyroid approach in several articles published in International Orthopedics and GSCS. The goal, my goal, and your goal should be to adapt the level of desired stability based on the patient's functional objectives, the preoperative stability achieved, and the patient obesity. It's a very important point. For young athletes with high functional demands, the suture of the LCL and the radial head is every time fixed. And the LCL and radial head fracture should be addressed for every patient. High athlete, high level function, and low level function. You have to fix it because you have to fix the radiocapitular joint. It's good for everyone. But for patient without a high level function objective, the tip fracture of the conoid fixation is indicated when valgus instability persists despite reattachment of the lateral collateral ligament complex and the radial head fracture. However, it will be systematically indicated in case of obesity to restore varus stability in patients with elbow subject to significant varus gravitational stress due to the weight of the forearm. It's a very important point. For a patient with obesity, if you want to avoid a persistent varus instability, you have to fix the anterior capsule and you have to fix the coronary, in fact. I will also perform this systematically in patients with high functional demands because I want to obtain a perfect stability in postoperative period. And furthermore, obviously, I will fix mid-transverse fracture regardless of the patient population. And most often we are retrograde screwing because it's very easy, very fast. And I can do after a medial approach in more, if needed. Regarding the MCL suturing, I recommend the systematic approach for patients with high function goals, especially for patients with valgus strain in their sport or in their work activity, and those with significant ulnar neuropathy, or for patients with persistent valgus or significant PRI despite the fixation of the previously mentioned structures. Obviously, if you have a patient with a persistent instability, even if you have fixed the radial head and the LCL, you have to, and the coronary, you have to fix the MCL. So the myth of cerebral triad leading to a very poor outcome is no longer relevant now. The aggressive fixation of the elbow, stabilizing structure according to a simple principles. This simple principle is fix it, move it. More you fix, more you move, and more you will have a good outcome. And I think this principle has transformed the prognostic of this cerebral triad. So now we can say that the myth of the cerebral triad sorry, there is a problem with it, lags a lot. Now there is not a myth of cerebral triad, and it's through a better understanding of the dynamic contribution to elbow stability, which has allowed for enhancement in our surgical protocols. So better you know the the biomechanical of the elbow, better will be your result and stronger will be your fixation. Thank you for your attention.
Thank you, Pierre. Pierre, you can stop sharing. Thank you,
Perfect.
Pierre, for this beautiful presentation. Few questions from our side. Pierre, I was just looking to the paper published by Pierre Mansart from Toulouse, France. Yeah, in Injury 2015, right? So there's a paper that looked at, I'm sure you've seen that, approach to terrible triad. Now, if you have repaired everything, LUCL, the radial head, and the coronoid, and you still have some instability, you go medial and fix the MCL, or you put on a dynamic elbow fixator, right? Am I right?
Yeah. Elbow fixator, no, I don't like it. I never use elbow fixator. I think it's not a good device. All this paper are, you refer to paper that are literature review. I published 2 or 3 papers about it, about peri and complex peri, and it's based on my clinical experience and my lecture. For me, it's like my presentation, fix it, move it. More you fix, more your fixation is aggressive, and more you can have a better stabilization of your elbow, and more you can obtain earlier mobilization. So if you obtain a good stability in postoperative period, you can obtain a very aggressive mobilization after and obtain a good range of motion. So you have to be aggressive in intraoperative, aggressive in postoperative to obtain early good result. I think it's my philosophy, but it's a philosophy good for young patient. Obviously, if you have 70 years old, you don't have to be aggressive. You just have to be careful with the structure and just to obtain a good stability and a good function, but very not aggressive. You have to be smooth for this patient with conservative treatment for the MCL. But for a young patient with a lot of valgus strain, you have to be very aggressive because there is a risk of persistent instability, pain, stiffness, and osteoarthritis at long term. We don't know exactly the risk of osteoarthritis at long term, but there is a risk, obviously, and we have no really treatment for it.
And Pierre, how do you get the coronoid into position? The approach that you take is the lateral side, right? You go on the lateral side, right? So
Yes.
do you get the coronoid from the same approach, or you want to use a different technique?
I have different technique. It depends of the patient. You know, when you have to operate a patient with a very obesity, it's very difficult to obtain a good fixation of the coronoid because the approach is very difficult. Very difficult because there are a lot of soft tissue to deal with it. So it depends, but there is one rule: never put your elbow like that for a medial approach in a patient, in an obese patient, or in a patient with not good tissue. Never do it before having fixated your coronoid fracture, because you're going to have an instability when you're going to fix your MCL and coronoid by a medial approach. The medial approach to fix the coronoid is for patients with very good tissue and with not a huge instability in valgus. You have to fix it because he has a high level of instability, but I prefer use a medial approach only for patients who are not obese, for example. And so for patients who are obese, I fix the coronoid by a posterior approach or by a lateral approach, but I open very largely, I open the epicondylitis, and I have a huge approach, and I can fix it with a strong fixation. But I secure it before coming to the medial side for the MCL always.
Thank you, Pierre.
Yeah.
Pierre, we're also joined by Loy. Loy Al-Khatib is an orthopedic surgeon from Dubai. Loy, welcome to the show. Any questions to Pierre, please?
Hi, Pierre. Thanks a lot for this impressive presentation. We talked before. I told you I like your presentation. I like your slides anyway. So I will go back to Hitch's first question. He was asking you about the internal fixation. I think he meant the IJS, the internal joint stabilizer. This is the dynamic stabilizer, which is something trending now in the States. What do you think about it? Is there any place to use it just to protect your repair in the first few weeks? Yeah.
I will be very clear. I think it has absolutely no place in cerebral triad. No place. Why? Why? Because I never use it and I never have a chronic elbow dislocation. You know, I never have a big, a critical failure with anchor. Okay, so I think it's very simple. You have injury of your ligament, you have to suture it. Okay, and you have bone fracture, you have to fix it. And I think it's enough to obtain a congruent elbow. AGS is very interesting for patients who cannot fix all the structure because he has a dissection of the arterial brachial, a dissection of the brachial artery, or he has an infection, or there is a cutaneous defect. You cannot approach this structure, so you have to fix it. So how are you going to do? If you have to operate this patient 1 month later, maybe it can be useful. But if you have a patient in front of you with a terrible injury, anchor, screw are enough. You don't need it. You don't need it. You have to fix it because biology is better, always better than this device. I think this device is very interesting when you cannot operate this patient in the good timing, or you cannot have good tissue to fix. It's like, it's better than an external fixator. But for me,
True.
fixator has no.
Fair enough. That leads us to the next question, timing. What about timing? Do you rush these patients, take them immediately to surgery, or do you wait or do you start with physio? What do you think about timing?
Timing. It's not a really emergency, in fact. You have to deal with the dislocation. Obviously, you don't let the patient with a dislocated elbow, so you have to reduce it. But after, you can deal it in 7 days. Because it's just ligament suture, radial head fixation, and sometimes coronoid fixation. So you can do it in the week. I think you have to avoid to fix all in the night, for example. You have to fix it in good condition. You have to talk with your patient and to explain, I'm gonna do the surgery, and a day after the surgery, you are with a physiotherapy. So you have to manage all the things in the post-operative period. It's better to fix the date of surgery, the good timing, and fix the post-operative treatment in the preoperative period. So it's better than operate the patient and after ask the patient, tell to the patient, find a physiotherapist, and they're gonna lose a lot of time with this approach. You have to fix it.
Totally agree, Pierre. I learned during my trauma fellowship and upper limb reconstruction fellowship, I learned that one of the most critical things to tell the patients about it is the complications, such as extension. This is just a remark here, extension deficits. So the patient will not go back. Most of the time, they will not regain the full function, and there might be 5 degrees of extension deficit. Do you agree with this statement?
5 degrees
of extension deficit. They will not be able to fully extend their elbows. They are nasty injuries. And most of us, as a junior doctors, or let's say junior doctors, when they just take the consent form or consent the patient, they forget to mention this possible complication.
Yeah. In fact, there is two main complications to the cerebral triad. There are a lot of complications, but the two complications are earlier the stiffness and instability, and at long term, the osteoarthritis with pain and earlier is the stiffness. We know how to deal with the stiffness. We have to obtain a good fixation and an immediate mobilization. And you have to talk with the patient and to explain there is a risk of stiffness, even if we will do this protocol, this process. Maybe we cannot control everything, but we're going to do the maximum to avoid it by a preoperative immediate mobilization. For the long-term osteoarthritis and with pain, we're going to fix a lot of things to obtain a macroscopic and microscopic stabilization, but we cannot predict exactly the risk of osteoarthritis. It's the same point. We're going to do our maximum, but we don't control all the factors of stiffness and osteoarthritis.
That's true. Maybe the last question from the audience. What's your preferred approach? Would you use a single posterior approach or do you do two single incisions?
Yeah, a single posterior approach is interesting, but I don't do it. I prefer a lateral approach, cocher in French, a lateral approach, and I can fix the radial head, the coronoid fracture often time. It's often a tip fracture, so it's just an anchor, and I fix the LCA. With this approach, my elbow is stable, in fact, oftentimes. And for patient with a high level, with an objective of very good fixation, I'm doing a minimal invasive approach over the top, straight to the insertion of the MCL, and I fix it by an approach of 3 centimeters, no more. If I have a patient with a ulnar neuropathy caused by the valgus strain, I'm going to do a FCU split to obtain an ulnar nerve neurolysis and fix the MCL.
Awesome.
Supposed approach, I never do it.
Okay. We used to, or I'm using a single posterior approach, so I can go medial and lateral if I need to go medial as well.
Yeah, it's very interesting, but I think by a posterior approach, it's very difficult to fix very well the MCL in between my hands. It's very difficult to be really in an anatomical point of insertion for the MCL when you are posterior. No?
That's a bit challenging. You need to more dissection, that's true, but you still have one single incision. And for the MCL, I think you need to hit the insertion sites, and you can get into the coronoids. Thanks a lot, Pierre. That's
Pierre,
wonderful.
Pierre, I think that's all the questions that we have for this session. Thank you for yet another brilliant talk, and really look for more in future. Thank you so much.
Thank you.
Bye.
Cheers.